Very much, and thank you to the organizers for inviting me. I've been asked to talk about HIV, hepatitis, TB, and STIs and how they interact with each other and how comorbidities and similarities. As you know, these are the diseases that are in a lot of prominence these days. 3 global health strategies were adopted last May, and there's a global health strategy on TB that was adopted before that. So there's a lot of attention on these infections. My job at ECDC is to coordinate the HIV, STI, and hepatitis program. So you can imagine we have a lot of work, and these are the infections that we directly have on each of these, some activities and some projects. I'll start with HIV. I'm going to restrict myself mainly to epidemiological data. I didn't want to get into the whole behavioral data debate because I would not have enough time. So if you look at the last data on HIV, it's 2014 data. We are finishing the analysis of 2015 in about 2 months' time. It's about 30,000 new HIV in the last year, about 6.46 per 100,000, that means population. Most of them are men, 3 to 1, and of these, most of them are men who have sex with men, and I think I referred to this in my talk yesterday for those of you who are here. The HIV is evenly spread throughout the European Union. Some countries have a little bit more than others, but most countries have HIV. Like I said, more men than women in all of the age groups. The main age group, as you would expect with HIV, is the most sexually active age group. So the 20 to 49 age group for both men and women. And that's because it is mainly sexually transmitted in the European Union. This might look like a complicated graph, but what it is actually, for each country, what is the main risk groups according to the epidemiological data. And as you go from left to right, you see the countries that are predominantly men who have sex with men epidemics, going to the ones that are predominantly heterosexual epidemics. And then there is, in purple, the impact of injecting drug use. That's dying out slowly as we have quite extensive protection in this risk group provided by harm reduction programs. But you can see that there isn't one picture. Every country's national outbreak, epidemic, is slightly different. And if you look at the proportion of HIV that are the main risk group, men who have sex with men, you can see that most of the countries have this as the main risk group. What I want to show you here, in the Eastern European countries, there was a very good survey. This is one of the few behavioral data I'll be showing you. Very good survey carried out by our colleagues that work on human rights based in Vienna. They did a very good survey amongst the gay population, and one of the questions for men who have sex with men was, for how many of you does your private doctor, your own personal doctor, know that you are gay? And you can see the answers over here. In the West, most of the men who have sex with men said, my doctor knows I'm gay. But in the East, still, even today, a very high proportion do not reveal that they are men who have sex with men. So this is a bias in the data in the East of Europe, where most of the epidemic is said to be heterosexual, but we believe that a lot of the heterosexual men are really men who have sex with men, but will hide it and say, I'm heterosexual. So we have to keep that in mind. So we think that actually the proportion of men who have sex with men with HIV is actually bigger than the data we have. If you look at the trends, AIDS is getting better. AIDS is because of the treatment rollout. HIV is not getting better. And if you look at, this is a log graph, if you look at the actual figures, AIDS is dropping quite fast. If you zoom in on the HIV, I presented this yesterday as well, the heterosexual men, heterosexual women getting better, injecting drug users low, and still it's getting better as well. And in men who have sex with men, getting much worse. Our prevention programs are not working there. But if you look at the big picture, the 53 countries of Europe, and we do this surveillance with our colleagues in WHO, so this is joint surveillance now. We have a tendency to divide the countries of the West, the countries of the center, and the countries of the East. If you look at the overall 53 countries, it's increasing. HIV is increasing. That's the purple line, 60% in the last 10 years. If you look at the West, the Western countries include, for example, Switzerland, which is not EU. So it's getting better if you include that. But if you look at the East, of course, it's a disaster. And that's mainly affected by the Russian data and the Ukrainian data. Also AIDS. You remember in the EU, AIDS is dropping fast, and that is a reflection of how good the treatment centers are at providing the right antivirals. But even in AIDS in the East, they're not getting the right treatment, and so they are seeing a lot of AIDS still. One area we are particularly focusing on in our agency, we are anticipating with the new treatment guidelines, that means treat everyone who you find to be HIV as soon as you find them to be HIV. We are anticipating very soon there will be an increase in HIV resistance to the first-line antivirals. This is already being seen in Africa, where there has been a big rollout in the last 3 years, and we anticipate this to happen in Europe as well. And it's not because the people don't take their medicines or mistakes by the doctor, it's a natural consequence of increasing the body of people on the drugs. For a long time, it was around 8-10%. It's still about 8-10% transmitted, but we anticipate this will go up to at least 20%. So we're putting in place some molecular surveillance systems to keep an eye on this. The impact of migrants on HIV. If you define migrants as being people who are not born in the country where they are diagnosed, a lot of these migrants, that's 37%, in 2014, 37% of HIV were people who were not born in that country, but a lot of these are actually people from the European Union moving within the European Union. For example, I am a migrant. I was not born in Stockholm, but I work there. So the definition of migrant is a bit loose here. It's not refugees. Refugees do not have HIV. Very rare. And again, if you look at the proportion of HIV diagnosis in migrants, there's a big difference between the countries. What's actually happening in our surveillance system, we're actually seeing a decline in HIV amongst those people who are not born in the country they are diagnosed. And a lot of this is impacted by, for a long time, we had migrants from high endemic areas of Africa. And that group is now coming down quite significantly. Not so much the people are not coming to Europe, but the people with HIV are not coming to Europe. And that's an impact, I think, of also better prevention in Africa and better rollout of treatment in Africa. Because treatment does prevent. If your viral load is down with the treatment, you cannot really transmit the virus very well. Another interesting fact about migrants in the EU, a study by our colleagues in the UK, they used complex algorithms to try and estimate when you got infected. And they do this by calculating certain parameters. Mostly important is the CD4 count. It's a cell in your body that's most targeted by HIV. And they count it. And the deterioration in the count is almost constant. So they can work back when they think you got infected. They did a study on migrants in the UK, and they found that probably the majority of migrants with HIV in the UK actually got infected after they moved to the UK. So the migrants themselves are a vulnerable population after they move into Europe. And this is an interesting finding that we need to keep in mind when we blame migrants for bringing HIV to Europe. We're actually giving it to them in some cases. And the CD4 count is another index of how well your screening programs are working. Do people come for tests? People who are most exposed to the virus, are they coming for the test early? And when the CD4 count at diagnosis is below 350, we consider it to be very late. This person has had the virus for a number of years and didn't know, so he's probably, or she's been transmitting the virus without knowing. That's not good. We want to bring this up as high as possible, but still it's a problem in many countries. And this is a measure we use to see how well those countries are doing in bringing people for the test, those who need it. Another parameter that you've heard a lot about, the 90-90-90. The first column of the 90-90 is all those people with HIV, includes those who know and those who don't even know themselves they have HIV. That's the first column. The second column is of those who have HIV, how many are diagnosed? And of those diagnosed, you go to the third column, how many are in care, how many are attending the clinic? And of those attending the clinic, how many are taking their medicines properly and their virus load is at the lowest level possible. And you can see that if you take the 90-90-90 for Europe, we are very far behind. We're nowhere near it. And it's a target we will be working on more to see how we can improve our figures. So in conclusion on HIV, it's still a problem. If you look at STI trends, which I will show now in the next few slides, it's still a problem that we should worry about. And of course, men who have sex with men is the main issue, although sex in general is the main issue. And we're not doing very well with bringing people who need the test to come for the test. So let's talk about bacterial sexually transmitted infections. I showed this slide yesterday as well. Chlamydia. Of those that we monitor regularly, chlamydia is by far the most common bacterial sexually transmitted infection. And this is mainly because women especially are screened very often for chlamydia. So you find it a lot more. Men are not screened. So we understand that this estimate of chlamydia is a big underestimate because the men are not coming for their testing and they carry it many times without symptoms. There's a lot of gonorrhea as well. And gonorrhea is particularly worrying for us. It's a disease which is, again, mostly in north of Europe, but we think it's because they're not testing enough in the other countries. And if you look at the trend, the thin line, it's going up quite steadily, quite rapidly. And if you zoom in on those lines, you see that the main risk groups are men, either heterosexual men or men who have sex with men, but also in women it's rising. And one of the problems with gonorrhea is that it has co-infection with HIV. One helps the other, and the same risk groups are carrying these infections. We have a program to study gonorrhea and its reaction to the antibiotics, because this is something that we're very worried about. And this is the result of the trends that we monitor. It doesn't seem to be a lot of problem. There was worry in the beginning, 2006, 2007, especially with Cipro. But if you zoom in on the red line, that's azithromycin, that's a very powerful antibiotic. This is what you'll see, and it's starting to rise quite rapidly, especially in men. You see the women, it's coming down. That's why it looks straight. Women take their antibiotics as they're ordered to, men don't. That's a problem. Syphilis has not gone away either, and we are seeing a rising trend in syphilis. Again, It's patchy in Europe, and we think it's patchy because not everyone tests as much as they should. For example, Lithuania, we know, screen all pregnant women. That's a very good thing. We want to promote that more. Not every country does that. That's why Lithuania finds more infections. And again, it's rising, syphilis, if you look at the general trend. And again, it's mainly men who have sex with men. What's even more worrying about syphilis is that we're catching it late. So this is 2014 syphilis cases. Most of them are late cases. Just so that you remember, secondary is a number of months after you've been infected, up to a year. And early latent, and over 1 year you've been infected with syphilis and you don't even know, and you can't transmit it. So we're catching them really late. So we really need to think about our screening programs for syphilis because they're not working. And again, with syphilis, you get a lot of co-infection with HIV. Again, mostly in men who have sex with men. Chlamydia, the trend is quite stable, but it's very high. And like I said, the chlamydia, the focus is on women. There's no focus on men. Men are found to have chlamydia only when they have symptoms. So this trend line is an underestimate. What's worrying up to us about chlamydia is the particular strain of chlamydia that causes lymphogranuloma venereum. It's quite a nasty infection. It looks nothing like chlamydia. It looks more like the plague, if you like, big abscesses and buboes in the groin. And this is rising very fast. And this is very difficult, not very difficult, it's difficult to treat. And we're quite alarmed about this. And we are setting up new systems to get the data because we only have very patchy data about the European Union. And what I'm showing you here is just data from a few countries that are really following this disease. It's quite difficult to diagnose as well. And we are seeing how we can improve the diagnosis. So in general, even again, our colleagues in UK are really interested in STIs. They do a lot of research. You can see the general trends are not good, even in a country as organized as the UK. If I can conclude then about sexually transmitted infections, you have these increases which are steady and rising fast. You have men who have sex with men who are the vulnerable population for practically all of them. In other words, whatever we're doing to prevent amongst this risk group, it's just not working. We need to do much more. There's also, women are being affected by the side effect of increasing gonorrhea. They are also seeing increasing cases. Chlamydia, very, very high. And this situation can't go on. You've seen the lines. They're going all the way up. We have to do something. And we're hoping that a bit more political involvement, because this is all about money, screening and education. I'll talk a bit about hepatitis. If we talk about hepatitis B, the easy hepatitis B, easy because it's vaccine preventable. We have a very good vaccine, a very safe vaccine, a very well taken up vaccine as well. People don't really worry about the hepatitis vaccine. Still, we see about 22,000 cases every year, reported new cases. If you look at the map, it's quite difficult to interpret. And we think the map more reflects who is screening more than others. This is what we think the map represents. If you look at the difference between those who've had it for a long time, that's the chronic cases, and the new cases that have new infection, the new infections are coming down, and that's the result of the vaccine programs. The older cases are the ones who have come for the test, and, well, it's difficult to interpret, but we don't think it's increasing so much. But what it is a reflection of is that the treatment for hepatitis B, once you have the virus, is very poor. It's not a good treatment. The age groups, again, more men than women. It's more of a sexually transmitted disease, so it's the sexually active age group that's affected. And this is the risk groups, mostly heterosexual, and some infections within small clinics that can happen. If you look at hepatitis C, our data is not as good as hepatitis B because hepatitis C is mostly asymptomatic. People do not go to a doctor immediately after they're infected. Still, there's more hepatitis C detected than B. Trend line, it's quite stable. The age groups, again, it's the more sexually active age group, even though hepatitis C is not really a sexually transmitted infection. But the other risk behaviors, like injecting drug use, is also seen in that age, the same age group, more or less. So if you look at the risk group, it is injecting drug users still who are being detected with hep C. We think there's an artifact here because they're the ones most tested. So when they go for their methadone, they go for their rehabilitation, or they are incarcerated in prison or arrested, they're usually screened for hepatitis C because there's a high awareness. So we're detecting it more there. There's our colleagues who work in the cohorts of HIV have been mapping how much co-infection there is, HIV and hepatitis C, and there's quite a bit. It's difficult. Cohorts are not nationally representative samples, but are quite big samples. For example, in the UK cohort, is 60% of all HIV in UK. The Austrian cohort is almost, I think, 90%. So these figures are quite good. High co-infection rates. Our main problem with hepatitis C is the poor data we have. You can see there are very few variables that we have more than 20% completeness in Europe. And we're seeing how we can address this perhaps by doing seroprevalence surveys. I'll go on to tuberculosis now. A lot more tuberculosis than hepatitis B, hepatitis C, HIV, syphilis. There's a lot more tuberculosis being picked up. And I found that quite surprising. It's not my main subject, tuberculosis, but I find it quite surprising that a disease that's completely treatable, completely curable, and is easy to screen for, we still have so much, 5,000 a month, new infections, new clinically significant infections, not dormant infections. And of course, it's a problem in certain countries more than others. The trend line is coming down. That makes us feel quite good. So it should be coming down faster. So at some point, the target of eliminating TB, which we have in Europe, will happen. And what we are mostly pushing is that everyone diagnoses TB the same way. And we would like laboratory diagnosis because that helps us then to find out if the mycobacterium is actually resistant to any of the antibiotics. If you just do a chest x-ray and then start the drugs, you don't know if that person has multi-drug resistant or not. And in fact, the green line you're seeing are the proportion of TB diagnosed that are laboratory diagnosed that we are pushing for. And also with HIV status, that's a very important element because we know that HIV facilitates TB. There isn't a big increase, but you know, if I have HIV and I get TB, automatically I'm AIDS. It's one of the defining diseases. So it's something we keep an eye on as well. There's quite a proportion, but not something to be alarmed about. And of course, when you have HIV and TB, the treatment is so much more difficult. And when you compare with people with TB who do not have HIV, this is quite clear. Another area that I referred to before, multi-drug resistant TB, this is not coming down. Even though the overall TB is coming down, the multi-drug resistant is staying stable, so the proportion is actually increasing of those TB we are detecting. And again, it's a problem of certain countries. And the treatment success rate varies. Now the target should be 70%, but we're not getting there. And of course, you actually get people who die of TB in this day and age. It's quite amazing. And a proportion of the multi-drug resistant TB is extensively drug resistant, and these are much worse outcomes as well. Again, this is a problem in certain countries. What you're seeing here is, of those that are multi-drug resistant, how many are extensively drug resistant. So that's what you're seeing in the map here. And of course, the treatment, like I said, the treatment success is actually very low, and quite often you die from this type of tuberculosis. And if you look at migrants or foreigners, the proportions are, you see, the Scandinavian countries obviously do not have a lot of TB. It's mostly in migrants that they have their TB. I'm going to run through a bit more quickly now because I'm running out of time. I just want to stop on this graph. If you look at the proportion of those in migrants and those not in migrants, I think we heard yesterday, TB is one of those that we need to give a special care to in migrants. So I'll stop there. Thank you very much.